Welcome to this deep dive from the Book Podcaster. Today we're tackling something really central to mental health care, the therapeutic nurse-patient relationship. Our guide is Chapter 6 of Psychiatric Mental Health Nursing, Concepts of Care and Evidence-Based Practice, specifically the 10th edition by Townsend and Morgan. And, this isn't just about dry theory. We want to really unpack the principles that make these interactions genuinely healing. We'll look at what makes them unique, the stages they go through, and how nurses navigate all the complexities of human connection in this setting. Okay, so let's jump right in. What's the fundamental difference between a therapeutic relationship and, say, just a regular social chat?
That's really the perfect place to start. The material lays out some very clear distinctions. Think about why you talk to friends. It's usually mutual, right? You share, they share. The goal is often just connection, maybe enjoyment.
Yeah, it's a two-way street.
Exactly. But a therapeutic relationship, it has one primary focus, the patient, their well-being, their growth, their healing. It's definitely not centered on the nurse's needs or, mutual personal satisfaction.
So all the energy flows towards the patient.
Precisely.
Yeah.
And that difference in focus leads to other key distinctions, like the time frame. Therapeutic relationships usually operate within a defined period. Maybe it's flexible, but there's an understanding it's not forever.
Right.
And it's guided by specific goals related to the patient's health outcomes. Social relationships, they tend to be ongoing, open-ended, often without any set outcomes.
That makes sense. It's structured, not just open-ended hanging out.
Yeah.
What about rules or guidelines? Are there specific codes involved?
Oh, absolutely. That's a huge difference. Therapeutic relationships are bound by a strict professional code of ethics. Nurses have ethical duties, maintaining clear boundaries, always acting in the patient's best interest. Social interactions, they're guided more by personal choice, mutual agreement, much less formal. And another big one is emotional engagement. In a therapeutic relationship, the nurse aims for empathy, really understanding the patient's feelings, but needs to maintain a certain emotional neutrality.
Neutrality. How does that work with empathy?
It means not getting personally entangled in the patient's emotions to the point where it clouds judgment or blurs the professional lines. You feel with them, but you don't necessarily take on their emotional burden in the same way a friend might.
Ah, I see. It's like understanding deeply, but keeping that professional perspective. That sounds like a real balancing act.
It really is. And the text stresses how vital this balance is. Keeping that professional stance while still being genuinely compassionate is what makes the therapy effective and, crucially, prevents boundary issues that could actually harm the patient.
Okay, that gives us a really solid understanding of what makes these relationships distinct. Now, the source we're using talks about Piplaw's model, right? With 4 phases.
Yes, Hildegard Peplaw's model. It's foundational in psychiatric nursing. It provides a really useful framework for understanding how these relationships typically develop over time.
Let's dig into that first phase then, the pre-interaction phase. What's going on before the nurse and patient even meet? Sounds like homework time.
It kind of is, yeah. It's the nurse's preparation stage. A big piece is self-reflection. Before meeting the patient, the nurse usually reviews records, gets background info.
Standard stuff.
Right, but maybe the most important part is the nurse looking inward, examining their own potential biases, any preconceived ideas, maybe even fears or anxieties related to the patient's situation or diagnosis.
That self-awareness piece sounds critical, but maybe overlooked sometimes. Why is that so important right at the start?
Because our own stuff, our unexamined feelings can unconsciously leak into the interaction. The book is a good example. Maybe a nurse feels anxious about working with someone diagnosed with, say, schizophrenia. Acknowledging that anxiety beforehand, maybe talking it through in supervision, helps the nurse manage those feelings so they don't negatively impact how they connect with the patient. It's about clearing the way for a truly therapeutic encounter.
Got it. Like checking your own emotional baggage at the door.
Yeah.
So after this prep work comes the actual meeting, the orientation phase.
Exactly. The orientation phase is that vital first encounter. And the main goals here: build trust and establish rapport. This is where you lay the groundwork for everything that follows.
So first impressions are pretty high stakes here.
Definitely. The nurse has several key tasks: introduce themselves clearly, explain their role, what the patient can expect. Defining the boundaries of the relationship is huge too. Confidentiality, session times, things like that.
Setting the rules of engagement, basically.
Right. And setting mutual goals is another big one. Getting on the same page about what they're working towards. Plus, the nurse starts assessing the patient's needs, their communication style, their main concerns.
Seems like a lot to cover in those initial meetings. If you had to pick one thing that's most crucial in this orientation phase, what would it be?
Hands down, building trust. The source is crystal clear on this. If you don't establish that fundamental sense of trust early on, the real therapeutic work in the next phase becomes incredibly difficult, maybe even impossible.
Makes total sense. You need that safety net to do the deeper work.
Absolutely. Patients need to feel safe, respected, and understood before they can really open up and engage. Trust is the bedrock.
Okay, bedrock established. Now we move into the working phase. This sounds like where the heavy lifting happens.
That's a good way to put it. The working phase is where the active therapeutic work really gets underway. It's about exploring the patient's issues in more depth, their thoughts, feelings, behaviors.
So digging deeper now.
Right. The nurse helps the patient identify patterns, maybe challenge unhelpful ways of thinking or behaving. They work together on developing new coping skills, practicing healthier interactions. Promoting the patient's independence and building self-esteem are also really key goals here.
It's not just talking, it's about facilitating actual change.
Exactly. And the source points out this is also the phase where things like transference and countertransference, these unconscious dynamics, often surface and need to be managed. We should definitely talk more about those.
Yes, let's circle back to transference and countertransference in a moment. But staying with the working phase, it sounds like the nurse needs to be pretty skillful in how they approach things. It's not always easy, I imagine.
No, it requires real finesse. The text talks about balancing confrontation with empathy.
Confrontation. That sounds a bit harsh.
Well, maybe challenge is a better word. It means respectfully pointing out discrepancies or challenging behaviors or beliefs that are getting in the patient's way, but always doing it within a supportive, understanding context. It's not about judging. It's about helping them see things differently to enable growth.
Ah, okay. Challenging with compassion. Got it.
Precisely. Providing that safe space while also encouraging them to move forward.
Okay, so after all this work, eventually the relationship needs to end. That brings us to the termination phase. How is that handled?
Termination happens when the goals they set out are basically met, or maybe the patient is being discharged or transferred. And managing this ending is really important. It's not just saying goodbye.
Right, it needs care.
Yes. Key things include reviewing the progress made together. Acknowledging the patient's growth and accomplishments is huge for reinforcing change. Preparing them for what comes next, maybe ongoing outpatient therapy, maybe relying on their own skills.
Sort of consolidating the gains.
Exactly. And crucially, giving the patient space to talk about their feelings about the relationship ending.
I can imagine that might stir up a lot for the patient. Ending a significant relationship, even a professional one.
Oh, absolutely. The source notes that it's common for patients to feel sadness, anxiety, maybe even experience a temporary little regression in symptoms.
Really, like going backwards a bit.
It can happen. The ending can trigger feelings of loss or uncertainty. So the nurse needs to provide that emotional support, validate those feelings, and help them transition smoothly, reinforcing their strengths and the progress they've made. It's about providing closure.
Okay, that's really helpful. Now let's definitely tackle transference and countertransference. You mentioned these often come up in the working phase. They sound complex.
They are, and they're really fascinating dynamics. They're largely unconscious processes. Transference is when the patient unconsciously redirects feelings or attitudes from a significant past relationship onto the nurse.
Like seeing the nurse as a parent figure, maybe?
Exactly, that's a classic example. They might become overly dependent or seek approval like they did from a parent. Or it could be negative. Maybe they react to the nurse with anger or suspicion that actually belongs to a past difficult relationship.
So the patient is kind of playing out old patterns with the nurse.
You got it. And countertransference is the flip side. It's when the nurse unconsciously transfers their own unresolved feelings, experiences, or issues onto the patient.
So the nurse might react based on their own past.
Yes. For instance, a nurse might feel overly protective of a young patient, maybe reminding them of their own child, and that protectiveness goes beyond what's professionally appropriate. Or maybe a nurse feels unusually irritated by a patient who reminds them of a difficult relative.
Wow. That sounds like it could really muddy the waters therapeutically. How do nurses even spot this in themselves, let alone manage it?
That's where self-awareness becomes absolutely critical. Nurses need ongoing reflection. They need to notice their own emotional reactions. Why am I feeling so strongly about this patient? And the source really emphasizes the importance of clinical supervision.
Talking it through with someone more experienced.
Exactly. Supervision provides a safe space to explore these feelings, understand where they're coming from, and make sure they aren't negatively impacting the care provided. It helps maintain objectivity and those crucial professional boundaries. It's a non-negotiable part of ethical practice, really.
Yeah, I can see why. It keeps the focus where it needs to be on the patient.
Okay,
Okay, so we've covered the structure, the phases, these tricky unconscious dynamics. What about the core ingredients? What makes these relationships actually work?
great question. The text highlights several essential characteristics. First off, rapport. That initial connection based on warmth, genuine interest, and acceptance. It helps the patient feel comfortable.
Okay, feeling welcome.
Then trust. We talked about its importance early on. It's built through consistency, reliability, honesty. The patient needs to know they can count on the nurse.
Makes sense.
Respect is another big one, showing unconditional positive regard. That means valuing the patient as a person, period. Regardless of their diagnosis, their behaviors, their history, you accept their humanity.
That sounds incredibly important in mental health. Unconditional positive regard.
It really is fundamental. It tells the patient they are worthy of care and respect. Then there's genuineness, the nurse being authentic, real, not putting on a facade. Patients often sense insincerity, and it kills trust.
Being real.
Yeah. And finally, empathy, the ability to understand the patient's experience from their point of view. The book makes a great distinction here between empathy and sympathy. Sympathy is feeling for someone, feeling sorry for them. Empathy is feeling with them.
Stepping into their emotional shoes, like we said earlier.
Exactly. Truly trying to grasp their internal world without getting lost in it yourself or losing your professional stance. It's a deep, connected understanding.
So rapport, trust, respect, genuineness, empathy. Those are the building blocks. What can tear them down? What are the common roadblocks or barriers?
Yeah, things can definitely derail the process. A major one, the source points out, is unclear or inconsistent boundaries. If the lines get blurred between professional and personal, it really undermines the therapeutic work.
Boundary issues. Good.
Inconsistent behavior from the nurse is another barrier. If a patient doesn't know what to expect, it erodes trust. Obviously, if trust isn't established in the first place, that's a huge roadblock. Judgmental attitudes are toxic too. If the patient feels judged or disapproved of, even subtly, they'll shut down. And circling back to countertransference, a lack of self-awareness in the nurse can lead them to act in ways that aren't helpful, even if unintentionally. These barriers can really damage the whole alliance.
It really highlights how much rests on the nurse's shoulders, not just skills, but self-awareness and consistent ethical conduct. The source gives a case example, right, to see this all in action.
Yes, it does. It's a really helpful illustration. It involves a 24-year-old man admitted for generalized anxiety disorder and his nurse, Maria.
Okay, walk us through it. How does Maria apply these concepts?
So in the pre-interaction phase, Maria reviews his chart, notes his anxiety history, but also takes a moment to think about her own experiences with anxious people, just to check for any personal biases. Standard, but important prep.
Good start.
Then, orientation phase. She meets him, introduces herself calmly, explains unit routines to reduce his immediate anxiety about the new place. Crucially, she validates his fears, she acknowledges them. That starts building rapport and trust right away.
That validation must feel huge when you're scared and overwhelmed.
Absolutely. Then, in the working phase, she doesn't just talk about his anxiety, she actively works with him, identifies triggers, teaches him specific coping skills like grounding exercises, and she gently encourages him to face some of the situations he's been avoiding due to anxiety, that balance of support and challenge.
Putting the tools into practice.
Right. And finally, termination phase. As he gets ready for discharge, she reviews the progress he's made, like how he's now using breathing techniques consistently. She praises his effort and increased awareness, and they discuss how he can continue using strategies like journaling after leaving.
So reinforcing the positive changes.
Exactly, and the outcome described is really positive. He leaves feeling more confident, feeling like he was genuinely heard and understood, and empowered to manage his anxiety. It just perfectly shows how applying these principles, the phases, the empathy, the respect, directly contributes to the patient's recovery.
That's a great example. It really ties it all together. It's not just about managing symptoms day to day. It's about fostering lasting change and empowerment. So stepping back, why is this relationship considered so absolutely fundamental in psychiatric nursing?
Well, the source really drives this home. The therapeutic nurse-patient relationship isn't just a nice-to-have feature. It's described as the very foundation, the cornerstone of psychiatric nursing.
The bedrock, like you said.
Yeah. Exactly. It's a space where trust is built. And within that trusted space, healing can happen, change becomes possible, and patients can grow and move towards recovery. Mastering these skills, understanding the phases, managing the emotional complexities like transference, communicating with real empathy and intention, this is how nurses make a truly profound difference. It's the art and science of connection put to work for healing.
So as we wrap up this deep dive into the therapeutic nurse-patient relationship, drawing from psychiatric mental health nursing here on the Book Podcaster, it's so clear this is far more than just protocols. It's really about the skillful, intentional use of human connection to foster healing and growth. And, understanding these dynamics isn't just for nurses. It offers insights for anyone interested in how supportive relationships work. Think about those core elements we discussed: trust, empathy, respect, those clear boundaries maybe in your own life, your own interactions. What parts of this discussion really resonated with you? Does it make you think differently about what it means to truly help someone? Definitely some food for thought there. This has been a fascinating look at a vital topic.